Dr. Mounds is a professor in the Department of Physical Therapy at the University of Alberta. Her research focuses on increasing knowledge of activity behavior and its relation to functional and health outcomes in persons with neurological conditions, primarily stroke and multiple sclerosis, and the development of strategies to change and maintain activity behavior. Prior to Dr. Mann's appointment at the University of Alberta in 2003, she completed graduate work at the University of Saskatchewan and Oregon State University, and worked clinically as a neurological physical therapist in both Canada and the United States.
All right, thank you for the introduction and for the opportunity to talk to everybody today. It's been an hour or so now, so if you need to stand up and walk around, that's fine. So I'm going to finish up by talking about stroke, and some of the things that have been discussed already certainly apply to people with stroke. Nora shared with me some of the questions that were coming up before we started today, and so that's informed some of the learning outcomes. First learning outcome, the thing that I hope you'll be able to do after we leave, is to be able to describe the characteristics of people with stroke and the abilities, and then how that might impact physical activity. So we'll talk a little bit about contraindications, but more so about things you need to consider if you are going to work with people with stroke. And the second question that came up a lot was best practice. So I am going to talk about best practices around exercise and physical activity interventions for people with stroke. Okay, first thing is to make sure we're working from the same terms. Stroke is symptomatic neurological dysfunction. So symptoms oftentimes are changes in speech or weakness, balance, those kind of things. When somebody has a stroke, you can see evidence of infarction or hemorrhage on an imaging device, CT. Doesn't matter how long those symptoms last. If you can see it on an image, that's a stroke. TIA is a brief episode of neurological dysfunction, so sometimes problems with speech again or weakness, but you can't see it on an imaging device. Usually it resolves within about an hour. People with TIAs, who have TIAs, are at great risk of having a stroke. So we're going to talk about both of those groups today. The other thing that I'll mention just, and I can share these slides later, one of the best resources that I use with our physical therapy students, and I would refer you to, is the Stroke Best Practice Guidelines. There are guidelines specific to exercise, which I'll show you on a subsequent slide. So just like the others, I want to tell you a bit about who you're working with and how large the problem is. In Canada, 405,000 people have a stroke. That compares to, if you think of people with multiple sclerosis, which is a group of adults with neurological disease who tend to be more middle-aged, 77,000 people in Canada with MS. So stroke is a large number of people. In Alberta, we have 4,000 new strokes each year. And if you add in those with transient ischemic attack, it's 6,000. It is the leading cause of chronic disability in Canada. So if you see somebody with stroke, you will expect, and I have a slide later to talk about this, but 60% of people who have a stroke will have mild disability. 40% will have moderate to severe disability. In Alberta, we have rehabilitation centers in Edmonton, the Glenrose, Foothills, and the Fanning Center in Calgary. The people who are seen with stroke in those places have moderate to severe disability, but only about 15% of people who have a stroke will actually go to those rehabilitation centers. One thing to think about, and one of the reasons why we would do exercise and physical activity with people with stroke is that there's a lot of evidence that shows if somebody has one stroke, they have a 30% chance of having another stroke within 5 years. This slide, the only reason I just quickly talk about this slide, this is from our latest prevalence numbers, the Kruger study in Canada. And what we see is that as people get older, the prevalence of stroke becomes higher. And we also see that there is very little difference in terms of gender for stroke prevalence. So the majority of people you see with stroke will be 60 and older. Having said that, there are certainly younger people who also have strokes. And those might be the people that you see more often in physical activity and exercise settings. So what are the characteristics of people with stroke? I already talked about this point. 6 out of 10 people who have a stroke will have minimal or no disability. So if they come into your exercise center, you may not see any outward signs that that person may have had a stroke. Others may need some adaptations to be able to be active related to weakness, mobility, language, balance, fatigue, and shoulder pain. So I'll take each of those a little bit and talk about it. Weakness in somebody with stroke, most often it will be one side is weak, only one side is weak. The arm will very often be weaker than their leg is. Oftentimes in people with stroke, they will have mobility challenges such as walking slowly, balance challenges. If they're in an exercise setting, you'll need to be sure that there's no obstacles in the way. Language, some people with stroke will have challenges communicating outwardly, so expressing themselves, but also sometimes in taking in instructions. You'll need to work individually with people to help figure out how they would like to communicate best. Fatigue, Bob talked about fatigue, but it certainly is a problem with people with stroke, probably related to 2 things. The first one is deconditioning, but the other one is stroke is a brain attack. The brain works to heal itself, and that is very fatiguing. I'll talk about shoulder pain on the next slide. I've got a slide there. Probably the biggest thing you'll see with stroke is no 2 people with stroke are the same. You should expect variability from day to day in the same person, but you should also expect variability from person to person. A stroke causes an infarct in the brain, and depending on where the brain is impacted, that's what the types of symptoms that you'll see in people with stroke. One of the most important points for us as people who work in terms of physical activity and exercise programming is people with stroke or TIA will have cardiovascular risk factors, almost without exception. More than 80% of people with stroke have high blood pressure. So you're going to be seeing people who are taking some of the medications that Bob was talking about. And there are some, the blood pressure is the most important safety aspect for people with stroke. You're going to need to monitor blood pressure. But they also have, people with stroke have a higher prevalence of diabetes than people who don't have stroke. They have higher prevalence of dyslipidemia. So cardiovascular risk factors are prevalent. Shoulder, on the left-hand side, you've got what we would call a normal structure of the shoulder. The shoulder is supported through some of the active movements of the supraspinatus muscle. When somebody has a stroke, and I said the arm tends to be weaker than the leg, if you've got weakness around the shoulder, then the shoulder at times will lose its support structures. And you can have subluxation. Subluxation doesn't always result in pain, but certainly if you're working with somebody with a stroke and you note that they have their hemiplegic arm has some weakness, you'll need to ensure that they can do upper extremity exercise safely and without pain. You'll need to ask about pain. I think stroke is one of our best examples if we can think of ways to collaborate between physical therapists and kinesiologists. In my mind, that's one of the best collaborations to ensure that people with stroke can be active safely and effectively. All right, well, why physical activity and exercise? I don't need to convince any of you that it's an important part of keeping people healthy, and in people with stroke, an important part of allowing them to function, to get in and out of the chair, to get in and out of a car. If we ever get released to go to the mall or wherever, a way to help people access their communities. So it's important. One of the, this is a slide from Jim Rimmer, who's in the United States. LOS is length of stay, but one of the most important reasons that we would help people with stroke to be active is to help to maintain some of the improvements that may have been made in the more structured rehabilitation setting like the Glen Rose or the Foothills. People make rapid improvements in those settings in health and function. And oftentimes you'll hear people with stroke talk about kind of dropping off the face of the earth once they get home. And I think, again, we need to think about how we can support people with stroke in the communities. The Sedentary Center in Edmonton is an exercise center for people with disabilities. Many people with stroke will go there. But we also need to think about how do we just help people to be active in their home. So by helping to maintain activity, we can hopefully avoid this dipping back down to a place where people are requiring more help to do everyday tasks, and or they're having health problems. The other thing I'll just talk about briefly in terms of the why is to improve capacity for everyday activity. This slide talks about VO2 peak. Some of you will have done a VO2 peak test, and you will know that this number, which is about 14 for people with stroke, is very low. But in the literature, evidence shows that that's about the range where VO2 peak sits for most people with stroke. So for somebody with stroke, ADL means activities of daily living. If they are walking around their house, sweeping, vacuuming, that is considered ADL. And for them to do that, that is at the top of their physical abilities, their exercise capacity. So exercise and activity can give people greater capacity to do some of their everyday tasks. And we also know that people with stroke, walking can be moderate intensity activity, whereas for most of us, strolling would be minimal activity, minimal intensity activity. All right, let's talk about best practices. I sort of have already started talking about this, and I've been using physical activity and exercise interchangeably. I would agree with Bob that we need to spend most of our efforts being concerned about physical activity. There are some people with stroke who can go to the gym and do planned, structured activity, but I would suggest those are not the majority of people. This is the Canadian Stroke Strategy, released an update to the best practice guidelines for aerobics for people with stroke, and I'm going to refer to those a little bit as we go through. Evidence specific to aerobic training, strong evidence. Exercise and aerobic training increases exercise capacity, which I just talked about in that macro slide. Strong evidence that balance and mobility are improved. We'll talk a little bit about if someone can walk on a treadmill. There's also evidence that can improve walking ability. Vascular risk reduction, level of evidence B is still strong evidence, but not as much from systematic reviews and meta-analysis. So there is good evidence that this is something that we should be encouraging the people with stroke that we work with to do. I'm going to just go over two of the recommendations. This is directly from the aerobics guidelines update. And the first one is who is should be screened, and the answer is everybody with stroke should be screened. Not everybody will be appropriate necessarily for an exercise program, but all patients can be screened, and there's strong evidence for that. When we talk about screening, and this is kind of a busy recommendation, but I'll walk through it a little bit. Because some of you are going to be doing a screening, and this is again an opportunity, I think, to have some collaboration between physical therapy and kinesiology on how we do this. So you are going to be asking your usual general information, asking about medications. That's important in heart rate response. Do they have diabetes? Talking about contraindications, I do have a slide about contraindications, but your most important contraindication will be around blood pressure. The majority of people that you see in the community with stroke will absolutely be stable in their recovery from stroke. It's really only the first week that physicians might be concerned about not wanting to have somebody exercising too vigorously. But again, just like Bob talked about, you may want to involve a physician. I think it's reasonable to just check with the physician in terms of the ability for exercise training. This third screen here, so screening for mobility, balance, swallowing. Some people with stroke will have challenges swallowing thin liquids and shouldn't be drinking water. They will know who they are if that's a concern. And then communication, which we talked about. Depending where you are, we talked about 6-minute walk already. That is one possibility to measure exercise capacity. Walking speed. Walking speed has been called the sixth vital sign. It's really walking speed. Measuring that would tell you a lot about ability in people with stroke and where you might go. So the Canadian Stroke Strategy has a couple of really nice modules around how to administer those outcome measures appropriately, and I can certainly give those to Nora so she could distribute. Do you need a stress test? In most cases, stress tests won't necessarily be an option. It'd be great if you did have a stress test, but for the most part, you're going to be working without a stress test. And the aerobics update on page 24 does have some examples of symptom-limited screening tests that you can do with people with stroke. So in a nutshell, I'm going to go over this pretty quickly. There's nothing that's all that different from some of what you've heard already today. Mode of exercise, we certainly do want large muscle groups. Cycling is great. Some of you, New Step is a sitting device. Walking, you could ask people to walk on the treadmill, though some people with stroke will not be able to walk for long enough or quickly enough to get any kind of cardiovascular training effect on the treadmill. So you likely will go to a cycle. If someone can do repetitive exercise on a treadmill by walking, then that is a nice way to get the extra bonus of improving walking ability. How long? At least 8 weeks, I would suggest. And, you know, behavior change, we need it to happen continually. Frequency and duration, nothing too out of the ordinary there. Intensity considerations, this is always the biggest challenge with people with stroke. What intensity will you have people start at? If you don't have a stress test, I would say you start low. So less than 40% heart rate reserve. Many people with stroke will have little or zero experience with exercise. So again, you would start low. Now, if you start low and you're measuring heart rate and blood pressure and using RPE, and it's clear that they are not working very hard, then you can increase intensity. But I would probably go at least a week at low intensity before you make too many changes, just so they can have some success at that level. If you're using heart rate, remember that people on beta blockers will have blunted heart rate responses. Beta blockers affect the sympathetic nervous system. Atrial fibrillation is a risk factor for stroke, so you will see people who have atrial fibrillation, and beta blockers are something that helps with that. Interval training, as Bob talked about, in many cases, you're just going to have to start with interval training. Continuous activity will be difficult and not sustainable. I'm going to talk briefly about strength training. The aerobics guideline obviously doesn't have strength training in it. The most recent strength training guidelines are in the reference at the bottom from the American Stroke Association from 2014. But strength training improves strength, and the principles are similar as what you would use with other populations. You can do strength training bilaterally. Considerations around that, if you're doing upper extremity strength training bilaterally, you know, it's quite possible to use the stronger arm almost exclusively. So you need to get a handle on, is the weaker arm having to do some work? You may decide to use no weights at all and do training of the weaker arm on its own, and that's fine. Training for function, I really believe that this is an important part of activity for people with disabilities. So think about dual ways to get at different things. So stairs, doing step-ups on stairs. You don't have to go all the way up the stairs, but that is an excellent way to increase lower extremity strength. Going from sitting to standing and repeating that. Boring as all get out, but a really critical move that all of us do repeatedly throughout the day. So it's a functional move, but also a strength training move. Monitoring the shoulder. I talked a little bit about the shoulder already, but monitoring means asking about pain. If you're noticing what would appear to be an abnormal movement of the shoulder, that's potential for injury. And again, the patient will often know how their shoulder pain is managed, but if you're doing an activity that's causing pain, you need to stop and make some adjustments. Strength training on the stronger side is a possibility. Paul Zare and Jonathan Farthing at the University of Saskatchewan, Paul Zare is in Victoria, have done a lot of research on cross-education and with people with stroke, where you're training the stronger side and getting some overflow to to the weaker side. That is certainly an option for people who have a lot of weakness on one side. Monitoring, I've alluded to this a bit already. You need to monitor blood pressure. So at initial testing, pre and post, and if it's the first time or two that you've seen somebody, you may want to measure blood pressure at a midpoint as well. Heart rate, there are lots of ways to measure heart rate now with Fitbits and Apple Watches. I don't know that the accuracy is fantastic, but again, it's a way to measure, and if you're using the same device on the same person, it will give you some indication of how hard they're working. Liz Reimer at the Fanning Center in Calgary, they buffed up the rate of perceived exertion scale with a picture to help their patients with stroke think about what their intensity level is when they are training. And that's a really nice way to have a sense of the intensity that patients are working at. Contraindications and precautions, so certainly unstable blood pressure. The patient might be able to tell you that, but again, that might be something to check with a physician. Bob Hanel and I actually did a study, I don't know, a few years ago now, where we did do peak exercise tests with people with stroke, and a cardiologist supervised those tests. These were his criteria, but they are fairly generally accepted in the literature. So if you have somebody who's exercising and their systolic blood pressure is more than 200, they should stop. Diastolic blood pressure, changing 10 millimeters of mercury in either direction. And then if your systolic blood pressure is dropping while exercise, that's abnormal. All of you are exercise professionals, and you know that when we exercise, it is normal that our blood pressure goes up, and we should expect that. But we do need to monitor it in people with stroke. The Fanning Center uses, and they do a submaximal exercise test. These are some of the other criteria that they use to stop the test. Increasing CNS symptoms, that's increased central nervous system symptoms. All right, I am got about 3 more slides, and I'm just going to talk about physical activity. So I kind of feel like Dr. Hanel and Dr. Cornier talked about this, but think big picture. We've started to do some work with interventions to reduce sedentary behavior in people with stroke. And for people with stroke who may be very inactive, and we want to change behavior, I would submit that the place to start is with reducing sedentary behavior. It's not with trying to get somebody on a bike and exercising for 20 minutes at a time. So I do encourage you to think big picture. And this is, again, what I talked about at the beginning. You're going to see variability in the abilities of people with stroke to be active. But some people you're going to want to start with monitoring how much sitting they're doing during the day. There are questionnaires to do that. And then try to reduce the amount of time spent sitting. And then work up to light intensity, moderate intensity. There are some exercise studies that are starting to come out with HIIT, high intensity training for people with stroke, but that's going to be certainly less common. And just a reminder again that for many people with stroke, walking a block might be moderate intensity physical activity. So the intensity is relative to the abilities of the person. Oh, I guess I took a slide out, did I? Apparently I did. Well, I'm going to just, before I talk about that, reiterate what was said earlier about changing behavior and use what you know about helping people to change behavior, because really we can have people exercise train for as long as we want, bringing them into structured settings, but if people are not carrying on with some level of activity, then our efforts have been wasted. So we really need to think about helping people to have success in changing their activity and to help them to gradually change activity. So this is my last slide. Discussion. One thing that we haven't really talked about today, but we can certainly talk about and have questions related to this. I do a session with our physical therapy students, and we spend a day talking about how do we help people with stroke to be more active, and what is the best way that we can help with the transition from these structured health systems to community settings for people with stroke. It's going to vary depending on where you live and where the people with stroke live. We are certainly finding that, and I actually have one of my PhD students is a telerehabilitation researcher. He works in rural Alberta, and they've actually used telerehab for a while now to work with people with stroke in remote settings. Can certainly do activity counseling, and if you're monitoring somebody somehow with a Fitbit or some device, then you can help them work through what does that information mean and how can we set goals to become more active. So the transition from healthcare system to community is critical, and the transition from physical therapy to kin, or do each of those professions work in both settings, both being the structured healthcare system and the community. There is strong evidence that exercise and physical activity are beneficial for people with stroke. We should be working with people with stroke to help them to be more active. The rehabilitation centers in Alberta are much more active now in terms of doing exercise training in the rehabilitation centers. Previously, I think it was, we're going to work on walking and functional tasks only, but certainly there is greater emphasis and inclusion of exercise training in rehabilitation centers. So we need to carry that through into the community. And then the last, just to reiterate the point that I've already made, that whole day activity is important. It's not just that 20 minutes of moderate intensity physical activity, it's the whole day and what happens. And all of us in this last 2 months, I would argue, have been more sedentary. We haven't had to walk across the campus between meetings or between our different settings, and that has made us probably feel not quite as well, amongst other things. But so whole day activity is really important. So ask people about how they spend their day and where they're active. So I will stop there, and we will ask whether there's any questions.
Okay, so there are some questions. The first one for you, Trish, is what is the risk of a second stroke after the initial 5-year period? And has this been tracked?
So after the initial 5-year period, I don't know the answer to that question, and I'm not sure whether, certainly we know that within the first 5 years, 30% will have another stroke. I'm trying to think whether there's any long-term studies that I can think of. I would, clinically, I would suggest that if somebody is healthy and is 5 years post-stroke, that their risk of having another one at that point is not as high as it would have been immediately after the first stroke. Are
you familiar with the benefits of pole walking for people? So people recovering from stroke, like building strength in the weaker arm, bilateral arm and leg action, helping with sitting to standing, etc.
Yeah, you said pole walking?
Yes.
Yeah. I can't think of any studies about pole walking, but absolutely the bilateral action of pole walking, the little bit of assistance to help people to stand up. I'm a big proponent of using walking aids when it's appropriate, and because oftentimes they allow people to be more active. I'm thinking particularly of four-wheeled walkers, which some people will not use, but those are fantastic ways to allow people to be more active and to carry things. If you're using poles, that's not really going to allow you to carry something. But those four-wheeled walkers have little trays on them, so if people with stroke have balance challenges, and many of them do, we need to think about ways to use equipment to help to reduce that risk. So just from a clinical perspective, I would encourage pole walking, absolutely. Yeah.
Okay. What tracking documents do you recommend to track sitting throughout the day? And then I guess the next question is related to that. Are there specific questionnaires you'd recommend?
Yes, tracking sitting throughout the day. That is challenging to do, because if you think about it, if you think of your day yesterday, if you did 20 minutes of, high intensity walking, you can remember that. But it's hard to remember the times you sit on the couch. There are questionnaires, the IPAC, the International Physical Activity Questionnaire, has a couple of sitting questionnaires in it. We use, it's a research grade device. It's called an Active Pal. The device goes on the participant's leg. It has an inclinometer in it, so you can tell sitting versus standing. We've used that device in a couple of our interventions because it's an excellent way to show a visual to people about when they're sitting and when they're standing, and give an estimate of sitting time. There are starting to be devices, not the Fitbit yet, but other commercial devices that say that they'll measure sitting time, but unless they have an inclinometer in it, it won't be that active.
This one's a bit of a comment. The transition to independent activity is a struggle. This person appreciates that in Calgary, the city and the Y have begun to offer gentle fitness classes that are drop-in. Connecting to this is key, and being aware of what is out there is very important. So I guess it's just an idea of what's available in Calgary. Next one, are we still avoiding overhead resistance training for the most part in patients with, okay, that one's a heart one, with heart-related chronic conditions? I know it's an absolute contraindication for high blood pressure. How about stroke patients?
Well, there's two reasons I'd be cautious about overhead strength with people with stroke. Number one would be to really have an assessment of their shoulder movement and whether or not they are able to lift their arms up over their head. I think the same kind of precautions related to blood pressure would apply to people with stroke. And as I said, it's rare to see somebody with stroke who doesn't have high blood pressure.
This person is asking if you can share the Borg pictorial again.
Okay, I could do that. Somebody just asked, I saw, whether we could share the slides as well, just after in a PDF, and I'm certainly happy to do that.
Okay.
But let me see if I can get back to that. Oh, that's easier said than done. Hang on, I think I've got it. Am I still sharing, Nora?
No, not at the moment.
Okay. Okay, well, I'm gonna actually not try to do that in case I drop this call. And
Okay, so maybe what we'll do, because we will share the slides with people afterwards, if that's sufficient, hopefully. If not, put another question in the bottom and we can try and get to it at the end. In Edmonton, the Step Forward program focuses on transition from rehab to community exercise. So people who aren't aware of the Step Forward program that's available. Do we have any idea why there is a low rate of continuation with activity following a structured program? Have follow-up surveys been done in research settings to see why patients are not continuing with activity either on their own or in a structured community program setting?
I think, I mean, we can draw on the general population literature on that. We really have to people have to understand why it's important. And I think if we just go back to talk about people with stroke in particular, it's really hard for them to become active. And we need to provide them with an understanding of what it means to be active. And I've had a lot of contact with people with stroke and with people with MS. And our general understanding of what it means to be active is running or playing tennis or things that are sometimes unattainable for these populations. And so I think that's one of the reasons why people with stroke drop. One of the other, Jim Rimmer has done some work on this with people with stroke. It is sometimes not feeling like they are supported in the community. And I think at the very beginning, Dr. Cornier talked about the ACE program in cancer and how there's a learning module for people who might work in the community with these different populations. I think we could do a better job of that with stroke in terms of providing education to people in the community who may be interested.
Okay. The next one is a comment from Norm Stock, although I'll ask people to answer him specifically or privately on the chat. It says asking about people having done any work with concussions. Comment from one person: as a recreation therapist in rehab, our role, particularly in the outpatient setting, is to support transition to community-based programs to develop ongoing exercise, physical activity routine. And then what are the findings that are available of community-based programs that are accessible to our patients? Sorry, let me try that again. What we are finding is that availability of community-based programs that are accessible to our patients is limited. We have worked with the YMCA, Bridge to Wellness, to establish a physical activity-based program for post-rehab folks, but there's a lot of work to do in the area of building capacity in the community. A strong component to keep people motivated to attend is the social aspect. So I think one of the things, like from my perspective, is that having more people in our community who are knowledgeable about stroke, so sessions like this, will help in having more programs available in community.
And one of the things that we are thinking about as the university tries to, deal with our new reality is we've turned one of our credit courses, which was telerehabilitation, into a non-credit course that anybody could sign up with and pay a nominal fee and take. One of the other topics that we've talked about offering is around stroke, because a number of people in the population who have stroke is large. And, if we can have, like you said, Nora, greater capacity in the community, people who feel comfortable working with people with stroke and who they feel comfortable with, then we'll make some real strides.
Regarding the board pictorial, if the slides are shared, that's fine. So we don't have to go back and try and share screen again, Trish. Next one, the problem with rec centers is attendance. Programs get cut off if the numbers don't warrant paying the instructor. Is there any funding support for setting up a community-based program? And in your experience, will the population pay for quality trained personnel to run these programs?
Yeah, that's the $64,000 question, isn't it? Certainly, and the people in Calgary can chime in, but Calgary probably has, some general sort of chronic disease management, physical activity programs that people do pay for. Places like the Sedentary Center in Edmonton, we do pay for. I think the fee is nominal, but yes, people will pay. That is the challenge. If you're in a structured healthcare center and you're working with a physical therapist, that's covered by healthcare. But once you get out into the community, then that becomes the patient's responsibility. There are some clinics, physical therapy clinics in Edmonton, and I think there's one in Calgary that say that they specialize and work with people with neurological conditions, and certainly they do see people in those settings. So, yeah.
Yeah. One other comment came in saying that, sorry, I've scrolled down too far. This person works in a rural primary care setting and as an exercise specialist, and recently qualified for the New Horizons grant, which is not specific to stroke, but does appreciate programming that helps older adults stay active. So that's an option for some people for funding programs.
And can I just comment on that? I think that's fantastic. The characteristics of people with stroke will be similar enough to older adult populations who have balance challenges, so that you could certainly put different groups together if that worked. In my experience, one of the things that people with stroke enjoy the most is being able to have some community with people with stroke and to be able to exercise together. So group settings are awesome. The FAME program, which is a program that is designed by Janice Ng, who's at UBC, they have basically you can download the FAME booklet, and it gives you guidance about what types of things you could do in an exercise program with people with stroke, and that can be very helpful in the community. And we have a physical therapy clinic in our building, and that's a program that we have talked about being able to offer to the community and have our physical therapy students exposed to working in that setting.
Another comment came in saying another consideration not mentioned is that a lot of people with stroke or concussions, etc., are facing limited finances. So financial barriers also exist for people trying to access programs, and some may have transportation problems getting to programs. Yes, definitely, I think to both. Town of Okotoks has been the recipient of a few grants from New Horizons, but the main focus is that older adults are running and managing the programs. In our case, the town is a support piece, but we look to the community for involvement. Many people end up on subsidized programs for community. The goal is to work together on valuing this and maybe a community program that helps prevent healthcare costs. Lots of good comments. Some of the PCNs in Edmonton have supervised exercise groups with patients that patients can access with GP referral. So that's good for Edmonton. Any other questions? I know that we're getting close to the end of our time here. Any other questions for Trish, or any other comments, Trish? Okay, so one of the questions that had come in on our Survey Monkey was how to support people when we can't currently see each other face to face. And one of the ways that we've connected with one of the people in our community is you can help your patients live actively through the Go Get Fit app. So it uses digital technology to virtually connect patients and healthcare providers for supportive regular activity. The healthcare professionals can efficiently view metrics, view compliance, and target support and follow up to those who are struggling. So Go Get Fit's a tool that's ready to engage patients in physical and mental recovery. and unisolate individuals through healthcare virtual touches. So that's one tool that people can use to connect with people right now when we can't. And even when we can, some people have, as we've said, transportation issues. Okay, so Centre News, our physical activity counseling toolkit has been updated. It looks modern, a little bit more modern than our old one. The original documents have been updated, and we also have the 5 new chapters, and those are available on our website. We will be sending out an evaluation survey in the next couple of days for this session, so that will help us with our planning through the next year. In addition, for those people who missed it, we were recording today's session, and we will be preparing a summary as well of the forum that will be shared on our website. So I want to take the last opportunity to thank our speakers who have shared their expertise and their time with us. And for those of you who are still on, I know it's been a long session, but I appreciate that you have taken the time to spend your morning with us. And I hope that we can continue to support you in your physical activity and sedentary behavior work in the community. So thanks again for the day. And if you have any follow-up questions, you can email them into our active.living@ualberta.ca email address, and we'll do our best to respond to those questions. Thanks, everyone.